Welcome. Over the next 15 minutes, we're going to reorganize everything you already know about surfactant around a single question. Why is the surfactant not working in this baby? Residents tend to file surfactant under one heading, RDS of prematurity, and that costs them at the bedside because a term baby with meconium aspiration, a baby bleeding into the lungs, and a baby with an ABCA3 mutation all look like RDS on the chest film and all need completely different management. By the end, you should be able to place any newborn with surfactant-related respiratory failure into one of 5 mechanisms and know what changes about your treatment in each. Before we talk about failure, fix the normal picture in your head. Type 2 pneumocytes start making surfactant around 24 weeks, but the pool stays tiny until the 3rd trimester, about 5 milligrams per kilo at 26 weeks versus 100 at term. That 20-fold difference is the whole of classical RDS. Composition matters too. Roughly 90% lipid, dominated by DPPC, plus 4 proteins. SPB and SPC are the small hydrophobic ones that actually spread the film. They are the ones we replace. SPA and SPD are large hydrophilic and are really innate immune molecules. Functionally, remember Laplace. Pressure equals 2T over R. Without surfactant, the smallest alveoli have the highest collapsing pressure, so the lung becomes a patchwork of collapsed and overdistended units. That is the physiology behind every finding on the film.
Here is the whole talk on one slide. 5 mechanisms. Not enough MAID, that is prematurity. MAID late, the near-term baby whose lung is big enough but whose timing was wrong. MAID but inactivated. Plasma proteins, meconium, blood, and bacteria destroying a film that was perfectly adequate an hour ago. Made wrong, the genetic surfactant dysfunction disorders. And not cleared, alveolar proteinosis, where the problem is too much rather than too little. Notice how the treatment logic already separates. In mechanisms 1 and 2, you replace. In 3, you fix the cause and expect to redose. In 4, replacement is futile. And in 5, you lavage. Keep these 5 columns in your head for the rest of the session.
Mechanism 1 is the one you already know, so I will spend the time on the parts residents skip. It is not only that the pool is small, the lamellar bodies are structurally immature and SBB expression is low, so what little surfactant exists spreads poorly. Layer on a chest wall so compliant it collapses inward with every breath, and respiratory muscles that fatigue quickly, and the baby cannot defend functional residual capacity even between breaths. The result is diffuse atelectasis, VQ mismatch, and intrapulmonary shunt. And the moment we intervene badly, big tidal volumes, high oxygen, we injure the very cells we are waiting on. That is why gentle ventilation is not a comfort measure here. It is treatment. Clinically, distress within minutes, worst at 24 to 48 hours, then improvement as endogenous production comes online. Treatment of mechanism 1, in the order that actually changes outcome. Prevention first. Antenatal steroids remain the highest yield intervention in all of neonatology, and delayed cord clamping for at least 60 seconds improves hemodynamics and reduces transfusion. Then stabilization. Keep the baby warm, start CPAP at 6 to 8 from the first breaths in the delivery room, and give caffeine early, under 32 weeks. Most babies above 28 weeks never need a tube if you do this well. Replacement. The threshold most guidelines now use is an oxygen requirement above 30% on CPAP of 6 or more. Use 200 milligrams per kilo of poractant alpha for the first dose. The head-to-head data favor it over 100. And how you give it matters as much as whether. If the baby is breathing, use LISA through a thin catheter. The meta-analyses show less bronchopulmonary dysplasia and less death compared with intubating. If you must intubate, extubate straight back onto CPAP. Mechanism 2 catches people out because the baby is 36 or 38 weeks and nobody expects RDS. The lung has enough alveoli. What is missing is the final biochemical maturation. The infant of a diabetic mother is the classic. Fetal hyperinsulinemia directly antagonizes the cortisol signal that drives phosphatidylcholine and SPA synthesis, so a well-grown macrosomic baby can behave like a 30-week preterm.
Elective cesarean without labor removes the catecholamine and steroid surge that both matures and clears the lung, which is why these babies often have a mixed picture of retained fluid and true deficiency. Asphyxia and acidosis matter more than residents realize. Below a pH of 7.2, synthesis stops and the film spreads badly, so a baby can even fail to respond to exogenous surfactant until you correct the acidosis. Same for cold and poor perfusion. So the treatment message here is different. Fix the physiology before you reach for a vial. Warm the baby, restore perfusion, correct the acidosis, start CPAP, and many will never need surfactant at all.
Mechanism 3 is where most term and late preterm respiratory failure actually sits, and it is the one residents handle worst. The type 2 cell is working. The problem is at the air-liquid interface. Anything that lets plasma proteins into the alveolus, albumin, fibrinogen, and especially hemoglobin, sets up a competition for that interface, and the proteins are surface active enough to win. The phospholipid film cannot form. Surface tension rises, and the lung behaves as if it were surfactant deficient, even though a lavage would show plenty of surfactant present. The clinical corollary is the important bit. Because the inhibitor is still in the alveolus after you give your dose, a standard single dose is often not enough. You need larger doses, you need to expect to redose, and above all, you need to remove the inhibitor. Drain the meconium, treat the sepsis, close the duct, stop the bleeding. Learn this list as a list, because on the ward, you will be asked to explain why a term baby with a clear cause still looks like RDS. Meconium is the classic. Free fatty acids, bile salts, and enzymes inactivate directly, on top of chemical pneumonitis and airway obstruction. Group B strep pneumonia is the great mimic. It can be radiologically indistinguishable from RDS in a late preterm, which is exactly why we start antibiotics on every baby we give surfactant to until cultures are back. Pulmonary hemorrhage deserves its own slide, and gets one next. A large PDA floods the lung with protein-rich fluid, which is why a baby who responded beautifully to surfactant on day 1 deteriorates on day 3. And note the last two. We cause some of this ourselves with volutrauma and oxygen. Treatment for mechanism 3 splits into two ideas. First, remove the inhibitor. Antibiotics, close or manage the duct, drain what can be drained, stop the bleeding. Second, support the lung gently while you wait. Adequate PEEP so the recruited alveoli stay open, volume-targeted ventilation, high-frequency oscillation if conventional fails, and inhaled nitric oxide when there is documented pulmonary hypertension. On dosing, because the inhibitor is still there, one dose is often not enough. Plan for repeat dosing, and do not read a partial response as treatment failure. In mild meconium aspiration, do not give it at all. The threshold most units use is an oxygen requirement above 50%. Pulmonary hemorrhage on the right. Understand what it really is. Not a bleed, but hemorrhagic pulmonary edema. Capillary leak driven by a big left-to-right shunt, classically on day 2 to 4, and classically after a surfactant dose improved compliance and increased ductal flow. Raise PEEP, treat the duct, correct the coagulopathy, transfuse, and then give surfactant once the bleeding is controlled, because hemoglobin was the inhibitor all along. Mechanism 4 is rare, but you will meet it, and in our population, consanguinity makes the recessive forms considerably more likely than the textbook incidence suggests. The clinical signature is a term baby with severe respiratory failure that has no obvious cause, who improves for a few hours after surfactant and then falls back. That transient response is the giveaway. You are topping up a system that cannot sustain itself. SPB deficiency is uniformly fatal in the first months without transplant. ABCA3 is the commonest of the group. The transporter loads lipid into lamellar bodies, so without it, the packaging fails. SPC mutations are dominant, often de novo, and much more variable. And do not miss NKX21. Check the thyroid and the tone, because brain-lung thyroid syndrome is easy to overlook when the lungs dominate the picture. Practically, echo first to exclude cardiac disease, then high-resolution CT, then a gene panel. Biopsy is rarely needed now. And when the diagnosis is SPB or a severe ABCA3 variant, the honest conversation with the family is the most important thing you will do that week. Mechanism 5 is included because it completes the logic, not because you will see it often. In congenital pulmonary alveolar proteinosis, the surfactant is made normally, but the alveolar macrophages cannot break it down because GM-CSF receptor signaling is lost. Surfactant piles up in the alveoli. So this is the one situation where giving more surfactant is exactly the wrong thing to do. The treatment is whole lung lavage. Radiologically, look for crazy paving on CT, and the lavage fluid is milky and PAS positive. The right-hand column is your safety net. Before you commit to any surfactant mechanism, make sure you are not looking at transient tachypnea, congenital pneumonia, duct-dependent cardiac disease, an air leak, a diaphragmatic hernia, or alveolar capillary dysplasia. An echo early costs you nothing and occasionally changes everything. A quick practical slide. 3 animal-derived preparations are in common use, and outcomes are broadly equivalent, with one exception. The first dose of Poractant alpha at 200 milligrams per kilo outperforms 100. So if you have Curasurf, use the 200 dose first and drop to 100 for repeats. Note the volumes because they matter for tolerance. Poractant is 2.5 milliliters per kilo. Baractant, 4, which is why Baractant is given in divided aliquots. Delivery. LISA is now the default for any baby with respiratory effort. A thin catheter passed into the trachea under direct vision while the baby stays on CPAP. The meta-analyses are consistent on less BPD and less death. Reserve Ensure for the apneic baby, or when LISA is not feasible. And if you do intubate, extubate straight back to non-invasive support, rather than settling in on the ventilator. If you remember nothing else, remember these 4 lines. Preterm with a classic film, replace and get the prevention and the delivery route right. Term baby with meconium, sepsis, or bleeding, the surfactant is being destroyed, so fix the cause first, use a bigger dose, and expect to repeat it. Term baby with no explanation who improves after surfactant and then relapses, stop redosing and send genetics. Echo, high-resolution CT, gene panel, and an honest conversation with the family. And the rare one, if the picture is accumulation rather than deficiency, lavage, do not replace. Every one of these decisions follows from asking which mechanism is in play, not from the chest film alone. 5 points to walk out with. Deficiency is only one of 5 mechanisms. Ask which one before you reach for a vial. Antenatal steroids and early CPAP beat any dose you can give after birth, so the obstetric conversation matters more than the vial. In secondary dysfunction, remove the inhibitor first, then dose bigger and expect to repeat. Pulmonary hemorrhage is hemorrhagic edema, so PEEP, the duct, and the coagulation come before the surfactant. And a transient response in a term baby means a genetics referral, not another dose. The sources are on the slide if you want to read further. The European Consensus Guidelines are the most practical single document. Questions?